Thank you for joining us on another episode of our podcast, The Canadian Breakpoint. So as many of you guys know, we are here live today at the AMR Symposium in Toronto. Had so many discussions this morning, and we're actually live kind of feeds and broadcasting onto the podcast today as well. And so we have a very special guest with us, Dr. Peter Daley, who I'm going to let introduce himself, and we're going to talk about another perspective of AMR.
Yes, hi from Toronto. I'm Peter Daley. I'm an adult ID physician and medical microbiologist, and I work in St. John's, Newfoundland.
Perfect. And so I actually just tuned into your talk about Canbuild AMR. And so for our audience here who obviously may not have been able to tune into the session today, can we give a little bit of a background in terms of what Canbuild AMR really is?
Yes, thank you. Canbuild AMR is an intervention designed to change family or general practice behavior in a sense of reducing antimicrobial prescription for patients who don't actually need an antimicrobial. And we think between a third and a half of all outpatient prescription is actually unnecessary. We have a long way to go in Canada in reducing unnecessary antimicrobial prescription. And that's really focused on two primary syndromes: upper respiratory tract infection, which is generally viral, and urinary tract infection, which is often culture positive but doesn't actually require antibiotic therapy. Canbuild is a peer comparison feedback that's given to providers, providing them with their personal rate of antimicrobial use in a comparison to peers around them in similar practice. And this is not a new idea. It's been studied many times, especially by Dr. Kevin Schwartz in Toronto. And meta-analysis has been put together, clearly showing benefits. So at a population level, this small amount of feedback can change physician behavior, which is reduction in prescription use. And it seems to be a suitable way to reach primary care providers that may or may not be part of a health system or part of a university system, that we need to communicate with them to benefit them, really, is to increase quality of practice.
Okay. And so, so we definitely talked about the audit and feedback processes. We heard from many different provinces in terms of kind of what their approach has been. So Alberta was mentioning they're using the MD snapshot, which seems like it's gotten ahead in the steps of prescribing and appropriate use of antibiotics. And are we looking at the initial prescribing rates, or are they getting kind of feedback in terms of their kind of length of antibiotics and for certain conditions? So is that something that's also being looked at?
Yeah, the feedback to the prescriber can be at multiple levels. One is initiation, one is duration, one is indication, and most provinces don't actually collect indication, so we have no way of judging that.
Right.
And then the fourth would be selection, which would be the antimicrobial prescribed. So, for instance, in our province, Newfoundland, Labrador, we have some fairly rudimentary level data, which is total antimicrobial prescription. We don't have any denominator, which looks at the amount of patients seen in the clinic or even the type of patients seen. We don't have indication, so we don't really know the reason that the physician prescribed the antibiotic. But we feel that even with a raw rate per doctor per time, that can be effective as well.
Right.
Some of the criticism that was brought out in the presentation just today was a physician may feel that the data does not apply to them in some way, that their practice is somehow different, or that the focus should be on other prescribers who are more the problem than the physician themselves are. And so I think tailoring that data more specifically to that physician's practice may be more effective than a general educational measurement or intervention, or a sort of raw total prescriptions, although that's personalized at some level. The more personalized it is, probably the more effective it is.
Right.
Yeah.
And do you feel like these stewardship initiatives, especially like audit and feedback, work better in a certain setting, so better in inpatient setting than they do in the community? And do we need better infrastructure, different infrastructure for acute care clinics and community care?
We know in Canada about 80% of antimicrobials used in the community. So really, of all the stewardship work, we should be focusing on the outpatient mostly.
Sure.
And in our province, we actually have an outpatient stewardship committee and an inpatient stewardship committee.
Nice.
Because inpatient is different. I mean, you're seeing the patient every day. You're getting microbiology results back every day.
100%.
You're looking at x-ray. You're looking at surgery. You're examining the patient. You're able to serially intervene.
Right.
Where in the clinic, you may discharge the patient with a prescription and you don't really know that the duration is appropriate. Maybe it's too long. Maybe it's the wrong drug. You don't often have culture data to use. Yeah. So to me, the bigger focus is on the outpatient. And this is really, I think, the best intervention we have for changing outpatient prescription.
And then I guess my kind of last question about Canbuild AMR would be, what kind of barriers have you guys faced to make this more of a national framework?
Yeah, we have plenty of barriers. The country is so divided provincially with separated health systems that don't talk to each other. They don't share data. They don't share money for sure.
Right.
And so in the province of Newfoundland and Labrador, we've been very slowly developing this. In fact, we're about to do this for the first time, so we haven't actually done this yet, which is surveillance of antimicrobial use. We needed to at least establish a pharmacy network first.
Right.
Then we had to talk to the college about, do they support this idea of giving this quality improvement feedback to primary care providers? And our college did not. Okay. It sounds like Alberta College does support this, but our province was not supportive. So we had to build this slowly. You know, who writes the letter? Who actually signs the letter? Right. We talked to the chief medical officer of health and we said, would you sign the bottom of this letter? And she said no. So it comes to who it's from, which is to do with the type of message that's received by the provider. Right. So we're still in development for this. We've been for many years, but we're getting very close. Ours is a collaboration between Quality of Care, which is our provincial Choosing Wisely organization, and our Health System Stewardship Committee, which is pharmacists and ID physicians and everyone else. So we're building this slowly, and we're behind other provinces in terms of implementation.
Okay. So yeah, so lots of barriers at lots of levels, but lots of people involved. So hopefully that's kind of the creating the treadwork for the next few
In fact, in a sense, it's building a quality improvement system that can be applied in other areas. Okay, right. So then why isn't that quality improvement applied to prescription of other types of drugs, or even applied to other quality initiatives? You know, are you doing a chest x-ray when it's appropriate? Are you doing a physical examination of the patient? Are you, documenting appropriately on your indication and this sort of thing? So there's lots that can be done, and it's a bit tough in the university kind of looking at the primary care providers and thinking that they're not doing good enough work. And we don't really appreciate all the stresses that they're under. But there are some fundamental quality improvement systems that I think are needed and are beneficial and are acceptable.
And so for, I guess, the folks out there that are listening in terms of who are involved in antimicrobial stewardship programs in their centers, whether it's community or inpatient, are there certain resources or places that they can contact Canbuild AMR for support? Because I think a lot of the times, like you mentioned, it isn't that nobody wants to do this, it's that we need the support system. And so it sounds like Canbuild AMR has kind of built a good network, or at least from ground up, to help other systems in Canada. And so are there areas where there's room for other provinces to join? And how does that happen?
Yeah. I mean, I think most provinces in Canada are already engaged at different levels. So he just showed a map of each and every province with a color on it. So I think most of us are buying in. We're in different stages of development or implementation.
Right.
You know, this is supported by CIHR research money, which is nice.
Okay.
So, Kevin did get a grant from CIHR to fund a national program in this direction. Okay. COVID increased research funding for infectious disease quite effectively. So we're in the benefit of some federal research funding to implement this, although it's not a lot of money. Really, it's not an expensive intervention either. Right. You collect your usage rates. So you need to know who your providers are. You need to have a system to notice what their rates of usage are. Somebody stuffs that into an envelope and posts it to their office and hope that they open the envelope and read the feedback. So it's really not a very expensive program. And I think, every province has a stewardship committee at some level, and it should be an important priority for each province. And I think it already is.
Yeah. Thank you so much for a fantastic talk. Thank you for coming on the podcast. And I think we'll definitely have future episodes that we want to do with Canbuild AMR to see kind of where the efforts have taken us. And thank you for working on such an important task.
Thanks for the invite.
Thanks.